All right. Hi, everybody. Today is a bonus lecture on neurosteroids. Dr. McDaniel is going to regale us with what neurosteroids are. I'd never even heard of them before I met him.
Right.
So very excited to hear all of this. So here we go.
Well, thanks, guys. I was asked to write this by Jim Willoughby for AAEM, and like Dana, I really didn't know anything about neurosteroids. And so, being a Kentuckian, we're simple folks, and so I've made this as simple as possible. But I tell you what, it's got a lot of rabbit trails. So I hope you guys don't mind. For ever ever since animals were domesticated, herders have known the castrated males were less aggressive. Um, and those who still have their balls are kind of butt heads. And the cylinder seal was from the early Uruk period in Sumeria. And the bulls are basically any surgical rounds anywhere in the United States. These guys are butt heads. And it is all in the head. And so I drew in some bull's horns for my little Davy Crockett chap, and we'll see how it's in the head. Now, that which makes males butt heads is testosterone. It was isolated from bull testicles way back in the 30s, and it is considered a classical steroid. And along with progesterone, cortisol, estradiol, even vitamin D, they're all active within the central nervous system. They are fat soluble, of course, and they just blast right across the blood-brain barrier. And they connect with their cognate receptors within the cell nucleus. And the hormone receptor dimer makes a transcription factor, which connects to DNA to activate or repress it. And this is a picture of progesterone having its way with the progesterone receptor in DNA, some artist's impression. So let's call these classical neurosteroids neuroactive steroids. That's the preferred term. Now, what's fascinating is way back in the 1980s, when I was still in residency, uh, a bunch of researchers were damn puzzled. They had taken animals and they cut out all the adrenal glands and the gonads and anything in the body that was capable of making classical steroids. But lo and behold, the brains contained all the steroids that the animals weren't supposed to have. And so, very puzzled, they found that, criminy, the brain itself is capable of making every steroid hormone for its own purposes. Now, production will vary by the brain cell type and the region of the brain, but they're made. And the steroids that are made absolutely within the brain are called neurosteroids. Now, some of them are indeed identical to classical steroids. I mean, that's what these guys found in the brain: progesterone, estrogen, testosterone. Where'd they come from? But others have been modified and they have actually different functions that are quite important. Now, we've been through these receptor types. There are two classes of steroid receptors within the central nervous system. And I just mentioned the classical neuroactive steroid and the neurosteroids will actually act on different type of receptors. The classical act on the hormones classical receptor, neurosteroids, something different. Those classical steroids that act in the nucleus at the nuclear receptor and act upon the DNA are called genomic receptors. And you've heard me mention that with thyroid hormone. And the other receptors are located outside the nucleus, the most important of which are located right in the cell membranes. And again, because they do not interact directly with the cell's DNA, they're called non-genomic receptors. I mentioned the non-genomic functions of T4 and reverse T3. Now, it turns out there are many different types of non-genomic steroid receptors. And some of them are actually transmembrane ion channels. They're called the ionotropic receptors. And when they bind with a neurosteroid, the ligand, the central pore of the receptor opens up and ions whoosh back and forth. And that will alter the synaptic threshold of the neuron, make it more or less excitable. The best study of these is the GABA receptor. When I was in medical school, they called it the Valium receptor. So times change. And there's a fairly artistic picture of it, side view going through the membrane and then looking right down the barrel of the pore. This is a schematic, which is a lot easier to understand. It binds GABA between blue and green. I don't even remember what BZD is. Mind your own business, man. And they are five different subunits, and you can have 2 or 3 or 1. And that is a really, really big deal, and we'll talk about that later. Now, those receptors that simply influence the ionic receptors are called metabotropic because they alter the cell metabolism, it would seem. So the differences between classical steroids, neuroactive steroids, and neurosteroids are simply to which receptor are they attracted irresistibly. The classic neuroactive steroids, most importantly, act at the genomic receptors, not so much so at the non-genomic. Neurosteroids, however, simply cannot get into the genomic receptors unless they have been retroconverted to a classical steroid, which doesn't happen a lot. No, the neurosteroids bind onto the non-genomic receptors, and doing so, they change the synaptic sensitivity, and they modify neurotransmission, and they kind of fine-tune your brain and your attitude. So I think of the genomic receptors is like Maestro Rubinstein here. He's playing the instrument, the nuclear receptor. But the neurosteroids are kind of like Abernathy here, the piano tuner. He just keeps the instrument in tune, although he doesn't massively play it. And you know, Abernathy only tunes once, if you remember the 5th grade joke. So how many neurosteroids are there? Well, I took my little list of the steroid synthetic pathways, and in green are the neuroactive neurosteroids that are inhibitory with a positive agonist effect on the GABA A. So it chills you out. On the other hand, those in vermilion here are stimulatory, and they antagonize the GABA A receptor, so they make the glutamate dominant, and they increase like the stress response or whatever. So this is not anything we're going to memorize right now, but I put it in the slide deck so you can look back at it if you want. And the article from which most of this was taken was Morrow's article in Pharmacological Therapeutics from 2007. The thing I want you guys to remember is the yin and yang of new endocrinology. These guys balance each other out. Now, I mentioned the GABA A receptor because it's a pretty big player for this lecture. It is a, quote, ligand gated. So when a neurosteroid hooks to it, it opens up. It has 5 subunits. And when it opens up, ions pour through it into the cell. Its preferred endogenous ligand is GABA, gamma aminobutyric acid, which is the major inhibitory neurotransmitter in the central nervous system. And neurosteroids in particular, one we're going to talk about a lot, allopregnanolone and tetrahydrodeoxycorticosterone, say that 3 times, enhance the GABA-mediated inhibition of transmissions, so it makes your GABA more potent, and it is said to undoubtedly participate in downregulating your central nervous system excitability, doubtless. So what does the GABA A receptor do? Well, they are players in response to physiological changes and threats. They're active in the development of the fetal brain, in responding to stress and physical trauma, emotional and physical trauma, to hormonal changes like, for instance, puberty, pregnancy, and the ebb and flow of the menstrual cycle. And they protect the brain from degenerative diseases and aging. And I'd like some more of that, please. GABA A receptors are also targets for a lot of our really familiar drugs, like benzodiazepines, why they called it the Valium receptor in 1974, ethanol, barbiturates, and general anesthetics, and more. Now, neurosteroids hit other receptors besides the GABA A. They affect the glutamate receptor, which is a G protein couple, like the TSH receptor, for instance. And God, wouldn't you know it, there are two types of glutamate receptors, ionotropic and metabotropic. And cripes, each one of them has subtypes. The metabotropic glutamate receptor type 1 is called central to excitotoxicity. And, you know, when the mother brings the really hyperactive kid into your office to see if the child has too much reverse T3 or if it's reacting to a food or a food coloring, you know, you would like a little less excitotoxicity, please. Increased metabotropic glutamate receptor activity has been associated with autism way back when. We'll get into that later. And testosterone also increases the glutamate receptor activity. So why are so many ADD-ish kids males? I don't know if that has anything to do with it or not. Nobody has looked. Now, the ionotropic glutamate receptor, this one is fairly big. The N-methyl D-aspartate or NMDA receptor is an excitatory glutamate-gated ion channel. There is a kainate receptor, AMPA receptor. They are both inotropic glutamate receptors. And neurosteroids modulate other receptors too. Sigma receptors, and they love androgens. Dopamine receptors. Dude, cannabinoid receptor type 1. I put Remy, who loves his food, because I always think of that with cannabinoids, munchie time. But in rats, the neurosteroid we're going to talk about, allopregnanolone, antagonizes the high of THC. It stops you from seeking food, and basically it sounds like it harshes your mellow. And no wonder, because allopregnanolone is a big player in causing PMS. And talk about a harsh mellow, huh? Loretta needs to come in. Boom. The norepinephrine, serotonin, oxytocin, and acetylcholine, both nicotinic and muscarinic receptors, are influenced by neurosteroids, as is maybe the neuropeptide. Why? Why? Don't ask me. Now, I got a case for you. 38-year-old woman. Every month, she has a really severe premenstrual headache. And the damn things last up to 2 weeks, from mid-luteal until the beginning of her menstrual flow, and she finally gets relief. And this has been going on for 9 years, since her second child. And she has other PMS symptoms too that don't, you know, last from 5 to 7 days, not as salient. She has been given the birth control pill, told to take it for 3 months without a period, so at least you only have a migraine every, you know, 4th month. But the pill has a lot of side effects for her. The woman does have insulin resistance. In fact, almost makes a criteria for metabolic syndrome we reviewed last week. She is hypothyroid, taking T4 only, and many other drugs, and of course, no nutritional supplements. When I say many other drugs, I'm talking about T4 birth control pill, metoprolol, bupropion, escitalopram, rizatriptan, omeprazole, and ibuprofen. And she quit taking allergy shots, Dana, because she had big latent delayed reactions and nobody knew her. She's on the standard American diet, best abbreviated SAD. It's freaking sad. She drinks 60 ounces of diet soda every day. I tell people drink 60 ounces of water. In her review of systems, she is no surprise chronically fatigued. She has no stamina. She's been gaining weight. She's losing her hair. She has obstructive sleep apnea, fortunately already treated with CPAP. She's freaking tired in the morning. She got a sweet tooth the size of a tusk, and she snacks frequently, and she's got a lot of symptoms of low blood sugar. On physical exam, she's only obesity class 1. She has a very large scalloped tongue that goes with the sleep apnea, big beefy nasal turbinates that go with the latent delayed hypersensitivity, and the blocked nose, so she has apnea, and she has an asymmetrical goiter. on blood testing. Her fasting blood sugar looks fine, but her fasting insulin is, oh my, 23. Remember, it should not be higher than 7 to be healthy. Her HOMA-IR is 5, and it really shouldn't be 2 or higher. Her thyroglobulin antibody was strongly positive at 38.1. And remember, that is a clue about autonomous function. And on the levothyroxine, her T3-RT3 ratio was only 7. Remember, it should be 12 plus or minus 2. So I gave her some suggestions. She did the labs above, and I didn't hear from her for 5 months. And, sometimes I just piss people off. You guys may not understand that about me because I'm so sweet to y'all. But, I thought, shit, did I forget my deodorant that day? She's gone. But she came back because she was now having allergy type headaches. And when I talked to her, her PMS headaches were completely gone. And she said, oh, I've got my outgoing personality back. And she feels like a new person. And what was she doing? Well, she was eating only half as much candy. She was taking saw palmetto that I recommended, 160 milligrams twice a day, cytosine AD, the adrenal glandular, and some multivitamins and vitamin C and D3. That's it. So what was going on that this simple-minded regimen I suggested worked like magic? Well, we know that she had a really robust fasting insulin, 23, that's higher than 7, to maintain the normal glycemic control of 87. So she was euglycemic and insulin resistant. Now, research in this fascinating little article, they took healthy ovaries removed from surgery, and they cut them into thin slices, and they soaked them in different concentrations of insulin to see what happened. And what they found is that in a dose-dependent fashion, the hormone insulin stimulates the ovaries, human ovaries, to overproduce the enzyme 5-alpha reductase. 5-alpha reductase is the rate-limiting enzyme by which progesterone and other classical steroids are converted to allopregnanolone and other neurosteroids. So if you're a biochemistry geek, which I'm not, you can look at this picture and go, dude, but, okay, there we go. So my patient had been making too much allopregnanolone. Well, so what? We see the amount of neurosteroids and, of course, their effects, they should be regulated. And they're regulated by local production and conversion of the systemic steroids that are floating around in the bloodstream and bombing across the blood-brain barrier. They should be balanced out by the antagonistic effects of other neurosteroids, green and vermilion, and also metabolic clearance. So it's like my paycheck money piles up and then it's gone. I clear it by buying stupid stuff, And so your brain makes neurosteroids and your brain clears it. Easy come, easy go. But if the clearance isn't working out, if my dad cut up my credit card, then you can't get rid of the money. If you have an enzyme problem, then you can't get rid of the neurosteroids and they can build up. Now, this is a statement that is, I will prove. In women with premenstrual dysphoric disorder, which is, PMS on steroids, or just regular PMS, high production of allopregnanolone exceeds the ability to clear. And too much allo is too freaking much. So why did my little lady do so well? Well, she was making too much 5-alpha reductase because of all that insulin and all that soft drink and all that candy and her insulin resistance. And she made too much allopregnanolone. And allopregnanolone was giving her migraines. So when I suggested that she take saw palmetto is a natural 5-alpha reductase inhibitor. She didn't get high allopregnanolone with her luteal phase. When progesterone went up, allopregnanolone didn't go through the roof. So we know that excessive amounts of allopregnanolone are related to PMDD, and we know that blocking 5-alpha reductase prevents PMDD, thanks to this nice cooperative study with NIH in North Carolina. So now we ask, Doc, I thought neurosteroids were really helpful and good. And the answer is, of course they are, if you've got the right amount and if they're balanced. Again, the yin-yang thing. Because neurosteroids jointly regulate CNS excitability. So again, neurosteroids regulate functions in the brain, like response to stress, okay, and trauma, but also puberty, the ovarian cycle, pregnancy, and just plain old reward. So let's look at some specific actions of neurosteroids so I can stop talking in generalities. During the acute stress event, the proper amount of allopregnanolone and similar, like the deoxyhydrocorticosterone, will protectively act via the GABA A receptor to downregulate the HPA axis stress response and let you chill out. Neurosteroids from ovarian hormones also modulate memory and learning, movement, and the perception of pain. At the end of the lecture, I'm going to get into the perception of stress and the perception of pain. Neurosteroids may have a significant role in the organization and reorganization, the brain plasticity stuff they're talking about, you guys, of gray and white matter during puberty and adolescence and as a result of emotional responses and events. Now, in the third trimester fetal brain, this was cool, I thought, so I threw it in. Allopregnanolone sedates the fetus, and it also protects against ischemic brain damage. So birth trauma, we got a couple of psychiatrists here. Birth trauma is blunted because the kid is auto-sedated. And if there's a little hypoxia and blue baby, the brain is protected by the effect of the neurosteroid, which I think is pretty generous of the creator. And just like in the fetus, the neuroactive steroids are protective of the brain in adults. So allo and the similar, green neurosteroids are neurotropic. They promote neurogenesis and they inhibit the death of neurons. So they are anti-apoptotic in the CNS. They will upregulate Schwann cell function, Schwann, and myelin secretion, and they reduce neuroinflammation, which would be awesome, like if you have COVID and you've lost your smell. So anyway, these effects maybe, possibly, they can help explain why there are sex-linked differences in susceptibility and the rate of progression of neurodegenerative diseases. My father-in-law just died last Saturday of Parkinson's disease. So, it'd be nice to know some of these things. Neurosteroids. Now, I want you guys to know this, that what we're looking at is study that shows an effect of neurosteroids, but it doesn't show the balancing effects. So this is kind of the information that people bring in before they think about the balancing. Say, oh, neurosteroids protect against seizures. Yes, they do. And neurosteroids relieve the perception of pain. Yes, they can. And you know what? The GABA A receptor is integral to pain processing, and allopregnanolone has been shown to act in the dorsal horns of the spinal cord to mitigate pain transmission. Ooh, and maybe other stuff too. And finally, allopregnanolone will actually reduce glucagon secretion, which is kind of interesting. I wonder why, if the patient was gaining weight because she wasn't pushing back and balancing the insulin effects. I don't know. Just random speculation. Now, here comes the yin and yang, you guys, because there are problems also associated with too much allopregnanolone. And here's where I'm going to give you a leg up over some pretty darn well-read psychiatrists, like one I know in New York City. Too much allopregnanolone is highly related to PMDD and PMS. And it totally goes with polycystic ovary syndrome. It's seen in atypical bipolar disorder, which I showed you guys last week, is about 95% of people of them have insulin resistance, panic disorder, chronic fatigue, and even Tourette's. But so some of our colleagues have looked at this as a paradox, and authors have written, why is this paradoxical? So it's not a paradox because other hormones are balancing, okay? So I want to take you in the Wayback Machine with Mr. Peabody and Sherman to 1953. I was still in nappies. Green and Dalton reported that big honking supraphysiological doses of progesterone could relieve PMS symptoms from women. And I know some docs who still treat that this way. So, giving a pharmacological dose of a hormone release PMS, well, is way too much of a good thing better? Because, during the PMS phase, progesterone is the highest it ever gets in the human body. So now they're making it way the heck more higher. So what's up with that? Well, animal studies show that, how about that? Certain of the GABA A receptor modulators, including allopregnanolone, have biphasic effects. So it's not a paradox. It's a biphasic effect, and it's a balancing effect. So with a biphasic effect, you go from good, and then too much is bad, and then way too much may be good again. So a lot of work has been done because nobody likes PMS, right? So they first looked at menopausal women whose hormones are going to be level, and they gave volunteers oral estradiol, and then they gave to them in incremental doses from 30 up, building up to 200 milligrams per day of progesterone. So we're going to give you a certain amount of estradiol, and now we're going to give you more and more and more and more and more progesterone. What happened? Well, you know what? There's a bimodal relation of mood and the amount of progesterone they were taking, which is reflected in the amount of allopregnanolone that was made from the progesterone. Women felt most negative at allopregnanolone concentrations between 1.5 and 2 nanomoles per liter of plasma. Bad news. We can't measure allopregnanolone in this country unless somebody started doing it. But this is research only, but we're giving understanding here. So the women with lower concentrations or much higher concentrations felt better. So here's a graph. I made this myself from Andre Eaton's data. And this stuff gets you into some weird journals, you guys. Psychopharmacology. Of course, for you psychiatrists, it may not be weird, but for an ENT, this is a damn weird journal. So, when your allo concentration goes from low to middling, oh God, people feel bad. But when you go to high again, they feel pretty great. How is more of too much now good? So there are three possible explanations I'll offer, but I want to start out with just restating a fundamental principle. The ratio of steroid hormones in the brain, that's key. So the first possible explanation is that the biphasic effects of allo that we've just seen may be mediated by the changing ratio of allopregnanolone to progesterone, which I will abbreviate P4 for the slide. And you know what? There may be a maximum ratio of allopregnanolone to progesterone because enzymes have a limited rate of reaction called the Vmax. And so if you have a limited amount of enzyme, then you can have more and more and more progesterone, but you're only going to get X amount of allo because that's all the Vmax you got, okay? Now, we know that PMDD corresponds with a high ratio of allopregnanolone to progesterone. So as Dalton and Green added more and more and more progesterone to their patients, she may have exceeded the 5-alpha reductase Vmax and thereby reduced the ratio, restoring them down to androgens. Oh God, I'm feeling good now. And I think that's very plausible. Now, secondly, and this opens the door to to my next lecture that follows on this, but it's so rarefied and obscure, I'm not going to give it to you ever. I'm sorry, it's just too crazy. But the number of GABA A receptors at synapses is variable. We've seen in Neuroendocrinology that the number of cell membrane receptors can be trafficked by the cell according to ambient conditions. So there's a direct relationship between the number of synaptic GABA A receptors and the strength of action at the synapse. So you may have just one lonely receptor sitting by itself with a cup of coffee waiting for fate to come, or you may have receptors all over the frickin' place. And how many receptors you have is important in determining what kind of bang you got from the cognate ligand. So the rate of removing and then replacing receptors, our cell membrane, our cell will pull a receptor out, maybe one with the wrong 5 subunits and put in one with maybe a better match for the environmental conditions. So this removing and replacing receptors is called endocytic sorting, and it regulates inhibitory transmission. And if you guys think this is bullshit, I want you to remember that the new injection drug that drops people with horrible high cholesterol down to incredibly normal levels or even low, it works by keeping your body from pulling LDL receptors out of the cell membrane. That's how it works. So this stuff isn't just swamp gas, okay? We don't know how the heck the cell decides which receptors to leave in the membrane and how many. But there's a second type of GABA A receptor change that is really credited. And this is where those subunits come in, because the subunits that make up the receptor determine the function. And the choice of which 5 subunits will compose the GABA A receptor from a menu of 19 different possible subunits you can put in. And that's more guys on the bench than a basketball team has, I think. But which 5 players you put in determine the function. And, you know, my subunits, I want these 5 guys. I still think this is the best basketball team ever born. But the subunit selection is dynamic. You know, Coach K on the bench there was pulling guys in and out, changing defenses and offenses, changed the type of team. Who's playing depends on what they're doing. So it's all basketball. Life can be summed down to basketball. But as allopregnanolone levels vary, GABA A receptor subunits are changed, which alters their sensitivity and function. And this explains some puzzling stuff later that I'll just touch on. So anyway, subunit composition is adaptively variable. As allopregnanolone levels rise, the GABA A subunits are reconfigured so that they will be less sensitive, and the receptor will be less sensitive to the higher levels of allo. But as allopregnanolone levels fall, receptors are made more sensitive. And that can happen really fast. And so here's an example of receptor sensitivity modification. If it's too noisy, or if your hearing is bad, if you need to hear louder, simple receptor modification. I love medicine, it's so easy. So studies have shown that the GABA A receptor has reduced sensitivity when progesterone levels are high, just as we might predict. The GABA A subunits will change over and through the ovarian cycle. And so when progesterone is high in luteal and therefore allopregnanolone is high, the GABA A receptor is blocking its ears. That's too much. And similarly, throughout pregnancy, when progesterone levels are super high, holy moly high. And, you know, here's a little LabCorp report, progesterone, follicular, luteal. Luteal phase is 1.8 to 23.9. How about third trimester pregnancy, 58 to 214? So when I say pregnancy has uber high progesterone levels, I'm not just goofing off. So how does it happen rapidly? Well, the receptors are plucked out of the membrane and replaced by newly constructed receptors, maybe with different subunits if your cell wants to have more or less stimulation. And these mechanisms are called receptor trafficking, clustering, endocytic sorting, and surface expression. So now you can read all of these crazy damn articles because I gave you the vocabulary. And even receptors can be recycled just as is, by the way. They don't have to be chewed up. Now, there's a third hypothesis to explain why the receptors are causing these problems. There can be polymorphisms in the genes that encode our subunits. And these polymorphisms encoding GABA A subunits are linked with schizophrenia, autism spectrum, and epilepsy with multi-drug resistance. So again, the stuff's in the literature. PubMed, as of 2018, listed 64 papers in the search field GABA receptor polymorphism. And I apologize, with my father-in-law's death, I didn't even think to go up and update this. But as of 2018, from 1989, not a single paper on polymorphisms talked about PMDD. And wouldn't it be lovely if somebody would? And then I mentioned the clearance of steroids, if that's dysfunctional. There are a couple of enzymes that degrade neurosteroids. For instance, the 17-beta hydroxysteroid dehydrogenase isoform 10 and type 3,3-alpha hydroxysteroid dehydrogenase that break them down. These are like other enzymes and are probably adaptively up and down regulated. So the question is, how fast does this occur? Does this occur quickly enough to prevent PMS after ovulation, just a few days? Are there individual variations of the rates? That would make sense that different individuals may have different effective enzymes. And are they subject to inherited polymorphisms and SNPs? Maybe. So a brief recap of this biphasic response described by Andreine is that receptor numbers and their subunit composition adaptively change so that the cell can adjust its sensitivity in response to variations of steroid levels. And while premenstrual dysphoric disorder and PMS has been attributed to high allopregnanolone, coming from the excessive 5-alpha reductase produced by the ovary bathed in insulin, along with high levels of progesterone and luteal, evidence suggests that changes in the GABA-A receptor itself may have a role. So it may not all be the neurosteroids, it's what they're affecting. So if the GABA-A receptor response to neurosteroid changes are abnormal just for any reason, from a polymorphism in a subunit's genetic code, you can get a bad outcome. So I think there are a number of ways these things can event. Now, this is a patient I never treated. Her father called me, and he's a physician, so we talked about her a lot. She's 30. She's had seizures ever since she had her first menstrual period. The seizure occurs usually on day 2 of her menses, so they are technically catamenial seizures. It's not exclusively, it doesn't have to be, but usually. She has 3 or 4 grand mal events a year and 4 to 6 partial complex events a month. God, she's tried virtually every anti-epileptic drug, no help. She took super high dose prometrium, didn't seem to help. I don't know what super high dose was in Dad's mind. I didn't get that far. Medical marijuana has helped the best. And she found that the 70% CBD was her jam. And she had a vagal nerve stimulator implanted. So that's, to me, an indicator how desperate the situation was. Now, she does have PCOS. She's got truncal acne, alopecia, hirsutism, hypoglycemia, and obesity. She was sadly born with a congenital hearing loss. It was diagnosed in childhood after a delayed speech acquisition, and so she's also wearing a cochlear implant. She's really bright. She's intellectual. She's artistic. She's witty. She reads at a high level, says Dad, and it frustrates the crap out of her that she's socially isolated with the hearing loss, with the seizures, and she's had to drop out of college repeatedly. It's really a tragedy. She's on a bunch of meds, lamotrigine, clobazam, paroxetine, metformin, obviously not one I use. Her labs have shown normal blood sugar, fasting insulin 12.4, higher than 7. Her HOMA-IR was 2.9, it's high. DHEAS was elevated, remember all that hirsutism and acne. Although dihydrotestosterone was mid-range normal-ish. Total T3 RT3 ratio, not bad, 9.5. And she is simply not willing to go on a low-carb Atkins type Mediterranean ketogenic diet. Why? Because everything in her life is crap. And I guess that's the one thing she has control over. And she said, I'm not going to do it. Now, her neurologist advised against taking a 5-alpha reductase inhibitor. I was impressed he knew about this, but he was concerned that it might increase the risk of seizures. So that's a guy who knows that allopregnanolone protects against seizures, but doesn't know that it about the balance, the yin and yang thing, I believe. So here's some questions. Do her seizures come from the excessive allo levels, or is it a coincidence? And of course, the other thing, it's huge, is why do her seizures start when progesterone and allopregnanolone fall? I'll mention that at the end. Is her congenital hearing loss due to a neurosteroid imbalance with abnormal fetal development? Remember the gray and white matter tracking in fetal development? Or is that just unrelated and coincidence? Is the success of her medical marijuana related to interaction between the CBD1 receptor and neurosteroids? Turns out the turns out the GABA A receptor also has a cannabinoid receptor in a little different part of the receptor than the allo receptor binding site, but still they're active. We know high insulin alters the GABA A receptor. Is high insulin affecting her seizures? She won't change her diet. Shit, would metformin, berberine, But most provocative, like I hinted earlier, why does the patient have seizures when her allopregnanolone levels have just fallen down from high levels in luteal to low levels in follicular? So I'm going to let that hang for a minute. I'm going to go back and take a little, just dress the stage. We know that high 5-alpha reductase is a hallmark of PCOS. The viralization is one of the two immutable diagnostic criteria for PCOS, right? And we know that in premenstrual dysphoric disorder, high 5-alpha reductase activity overproduces allopregnanolone from the robust progesterone substrate levels in luteal. And we know, thanks to NIH and Chapel Hill, that high allopregnanolone causes symptoms. Andreine found that, and blocking it, NIH, prevents the symptoms. So here's the first question. Can women get withdrawal symptoms as high levels of allopregnanolone fall? And the answer is yes. A common clinical model is postpartum depression. The woman has had really high progesterone levels for the previous 9 months. After delivery, progesterone plummets, and then her symptoms begin. So, Big Al, I said withdrawal. Is it just not too low allo? And it's a good question. Our thought patient's neurologist was concerned. And it is certainly true that many problems have been documented to feature low allo in the blood or CSF, including major depression, anxiety, schizophrenia, bipolar, and even abstinent alcoholism. And then there are other conditions also that have low neurosteroid levels. All kinds of seizures, including the catamenial epilepsy we're talking about, multiple sclerosis, Alzheimer's, dementia, and Parkinson's. And traumatic brain injury, PTSD, and chronic pain. So what the heck causes low allopregnanolone in these people? Well, low adrenals, like for instance, PTSD, I think. And then maybe the patient's not making enough 5-alpha reductase. But, look, in this patient, yes, allopregnanolone is low at the time of procedures, but I want to give you a little more information to flesh this out. There's an observation in PMDD. If there is no rise in allopregnanolone, there are no symptoms of PMS or PMDD. And this is the basis for the prophylactic treatment the patient got with the birth control pill, patient 1, and ovarian suppression with Lupron. So they will give these poor women who suffer greatly with PMDD Lupron and just shut down the reproductive cycle completely. So here's the thought, though. I want to call to your attention the fact that, yes, high allopregnanolone is required to produce symptoms. So if you block the allo, you get no symptoms. But also high allo precedes the withdrawal symptoms and the catamenial seizures. And by the way, menstrual migraines are in exactly the same boat here as the catamenial seizures. And menstrual migraines are a lot more common. So why do these women in case 2 feel bad when their allo is low and progesterone falls compared to when the PMS would feel bad when everything is high. And we see it with postpartum depression, with menstrual migraines, and catamenial seizures. Okay, well, we've seen that the GABA A receptor subunits, and yes, I'm pointing the finger at the GABA A receptor subunits. Just to be clear, it's the damn subunits' fault. The GABA A subunits will normally change throughout the menstrual cycle to cause reduced sensitivity and luteal. So the 77% of women who do not get PMS probably, well, they probably don't have insulin resistance to make a big challenge, but their GABA A subunits are changing fast. Coach K is on the job putting in the right player at the right time, making the good substitutions and winning the game. And those women who don't reduce the sensitivity when the allo levels rise in luteal get PMS or PMDD. They've left in the really sensitive receptor and they're not protecting themselves by doing that. And so the catamenial reason is the same, but it's the converse, personally, I believe. The GABA A receptor may too slowly return from a low sensitivity to a high sensitivity. So when GABA A falls down to normal follicular levels, when allopregnanolone and progesterone fall from the high in luteal down to the normally modest follicular levels, the GABA A receptor is still insensitive. And it goes, oh crap, I've got too little allo. And that makes just totally good sense to me. It's not getting the earplugs out. So I think withdrawal is due to an insensitive GABA A receptor when the allo goes back to normal. And postpartum depression has also been associated with altered GABA A receptor subunit expression. Bingo, that's what I'm talking about. And the researchers who found these things out said, yeah, we think this change is contributory to the depression. So just to state the obvious, that during pregnancy with progesterone levels in the 158 range, GABA A has to be insensitive to progesterone and allo. But then after delivery, when everything drops back down to 0.2, guess what? You have to have normally sensitive or even increased sensitivity for the allo, because the allopregnanolone levels are normal, but if you have an insensitive receptor, they are functionally low. And so I think that's why you have all of those other catamenial problems like migraines and seizures. So I've already stated all of that. Oh God, is it the receptors like I think it is, or could it just be a problem with the stupid enzyme switch? If the enzymes that break down the neurosteroids are induced to excessively rapidly clear it or improperly induced so that there's a delayed downregulation, you either will have too much or too little at the synapse. Makes sense to me. Now, I want to talk a little bit about that PCOS again. I didn't hit it hard during the GYN lecture, and this is the place, I think. So patient 2 also had PCOS, which was a big part of her problem. The increased 5-alpha reductase, like I said, is a hallmark of PCOS and a major factor in its diagnostic abnormalities. So 5-alpha reductase is the rate limiting step in the conversion of progesterone to allopregnanolone, along with some other neurosteroids. And so the excess of 5-alpha reductase, being the rate limiting step, is going to make excessive amounts of allo and cause trouble. And indeed, polycystic ovary syndrome women have a lot of CNS problems. And babies of women with PCOS also suffer. And so let's talk about that. The fetal brain is under construction. And in utero, the ambient steroid bath, the environment of neuroactive and neurosteroids, importantly directs the development of the CNS. So the so-called programmed hormonal changes will guide the sex-related morphological differences of many brain nuclei, And at least in the brain, you know, female brain different from male brain. So according to the current theory, okay, chromosomal stress is determined at fertilization. And a gene on the Y chromosome, the SRY gene, causes the gonads to develop into testes, and now you've got gonadal sex, the second kind of sex. But we also have hormonal sex because the fetal testes release androgenic steroids during the prenatal period, and what it does is it masculinizes the male body and brain. And like I said, full disclosure, it varies by species and by area in the brain, but that's what happens. The prenatal ovary releases little to no hormone. So in girls, the relative absence of androgens is associated with the development of a feminine body and brain. And therefore, hormonal sex is defined as the ratio of circulating estrogen to androgen. And at last, people are again talking about the Tao of endocrinology. So if there is an abnormal steroid environment, there can be a problem. Endocrine disruption at critical development stages may differentially affect the non-reproductive behaviors in male and female offspring. And here's a little quote from Weiss. The literature is filled with examples showing that the developing male and female respond differently to many chemical agents like PCBs and TCDD with subsequent expression in behavior from environmental health perspective. And this is way big time true for hormones, okay? Evidence from children of women with PCOS shows neuroactive steroid imbalances are also disruptive. So in a PCOS pregnancy, the in utero environment has too damn much androgens. And remember, girls aren't supposed to get those. Mid-gestational amniotic testosterone levels are greater in female fetuses of PCOS mothers compared to mothers who don't have PCOS. So the babies, the female fetuses are getting excessive androgens, okay? Infants of women with PCOS are more likely to be born either large or small for gestational age. Personally, I think that's because of the trophic effect of hyperinsulinemia, okay? And the effect on blighting the placenta for the little guys. But it turns out that testosterone also can explain the size difference in babies. Turns out male babies are a little bigger than female. And then even at birth, mothers with PCOS, the babies will have come out with high androgen levels. Cord blood androstenedione, remember that's a product of DHEA and the precursor of testosterone, is increased in both male and female offspring of women with PCOS. And girls' cord blood mean testosterone was elevated to the levels of male babies. That's a worry for the development of their brain because they got as much testosterone as the guys do. Higher free testosterone in cord blood correlated with lower newborn birth weights. Personally, I think that's the insulin again. And in girls, this also correlated with elevated anti-Müllerian hormone, and that correlation lasted right into the teens. Yeah, I'm not going to go down that rabbit hole. Here's a Swedish study of almost 24,000 autistic spectrum kids and over 200,000 normal control kids. And what they found was that maternal PCOS increased the odds of the baby being on the spectrum by 59%. So odds ratio 1.59. But if the problem was worse and the mother had both PCOS and obesity, then the offspring's chance of being on the spectrum was more than doubled, 2.13 odds ratio. So the Danes, not to be outdone by the Swedes, they took a look at the same thing and they looked at in utero neuroactive steroids and autism. And they found a strong linkage. They had stored amniotic fluid from 128 boys who were later found to have autism. And they found that all of the delta 4 hormone pathway steroids were elevated. And that's that damn little schematic I showed you of the 5-alpha reductase working on the delta 4. So all of these guys were elevated because presumably of 5-alpha reductase, because they're all the substrates. Okay, back to the Swedes. Yeah, them Swedes. All Swedish children born from 1984 to 2008 were examined. And maternal PCOS increased the risk of attention deficit with hyperactivity disorder in their children by 42%. But mothers with a worse problem, both PCOS and obesity, had still higher odds. 68% of their kids had ADHD. And the worst moms who had not only obesity and PCOS, but other features also of metabolic syndrome, now they were 2.6 times more likely to have kids with ADHD. So these kids, it's not necessarily just what they're eating and maybe the start they got in utero. The Aussies took a look at kids from PCOS mothers, and they found, wow, they had a lot of other increased risks, including asthma. 32% more likely to have asthma. We'll get back to that later. So intrauterine androgens seem to be related with pervasive development disorders. And although children with PDD, pervasive developmental disorders, generally are predominantly male, it was the daughters, not the sons, the daughters of the women with PCOS who were at increased risk. And that correlated with prenatal amniotic exposure to high levels of androgens. So let's look at another correlation between high androgens in the female brain. We know that girls who have congenital adrenal hyperplasia, and in order to make enough cortisol to stay alive, they have to make gobs and gobs and gobs of androgens. These girls also score higher on autism spectrum questionnaires than do boys with the same congenital adrenal hyperplasia or girls who don't have it at all. So there's something with the androgens in the girls' brains. Now, how does possibly prenatal androgen excess cause pervasive developmental disorders? And again, we got three different plausible explanations. So I'm going to run through these fairly quickly. So beyond just the organizing effect of the sex differences, CNS steroids play a really important role in developing the brain, as I said earlier. The neurosteroids tune the balance of excitatory and inhibitory. The classical neurosteroids alter the neurosteroid concentrations, and as autism and attention deficit seem due to an excitatory excess, we might speculate that unbalanced neurosteroids may be important. At least these authors of these studies have. Also, a guy named Hatanaka found that unbalanced CNS steroids interact with genetic predispositions to alter synapses. And he took maternal obesity mice and did something I'd never heard of called in vivo photon imaging. And he correlated high fetal androgens with abnormally unstable dendritic spines in the offspring, which alas persisted into adulthood. So you're jacking up their neurotransmission is what I got out of that. And this disturbance is also commonly found in a variety of neuropsychiatric disorders, including autism, attention deficit, schizophrenia, anxiety, depression, and other neurodegenerative disorders. And then third, is there a defect in the neurosteroid GABA A receptor signaling? Because excessive glutamatergic neurotransmission has been speculated and suggested to play a role in the pathophysiology of autism. And frankly, normal GABA A receptors are supposed to suppress that glutamate signaling. So again, we come back to that GABA A receptor subunit polymorphisms, and maybe they're not working as well. So you see, we've got lots of different lines coming back to similar common causes. So, little brief review. Pregnancies with elevated intrauterine androgens deliver children who have problems, to which girls are the most sensitive because they're not supposed to have those androgens. This includes androgen-related low birth weight, pervasive developmental disorders, developmental and metabolic disorders, and asthma. And this will segue to the next section, which I think was just fascinating, and I absolutely couldn't leave out of this lecture. Maternal stress provokes similar outcomes and connects neuroactive steroids with epigenetics. So we first became aware of this possibility in the understanding of the Dutch hunger winter. Now, you internists may remember the Dutch hunger winter also led to the diagnosis of celiac disease because the Dutch had only had potatoes to eat all during the war. During the hunger winter, when the Wehrmacht took all their food, they made a deal with Eisenhower that if he dropped food to the Dutch civilians, they wouldn't shoot down his airplanes. And so Ike dropped bread. And a Dutch pediatrician noticed a lot of children who had been sick all the time had been really well during the potato diet. When they got the bread, they got really sick again, and that led to the celiac and gluten. Okay, but babies who were born of women who were pregnant during the starvation of the Dutch hunger winter had increased susceptibility to obesity, diabetes, heart disease, and more things. And the babies who were in the second trimester during the famine tilted more to schizophrenia, schizotypal personality, and neurological deficits. And what's fascinating was these children passed their problems along to their children, including shorter birth length, greater adiposity, and worse health in general in later life, and more psychiatric problems too, by the way. And these findings are relevant to us. And this lecture, besides the fact they're cool, is that elevated stress increases levels of cortisol, also testosterone and other steroids. And chronic stress is linked with neurosteroid problems. McCarthy, I thought it was quotable, said the prenatal hormonal milieu influences the development of brain structures involved in cognition, memory, aggression, and mood. And I'm going to shift focus to Canada. The Quebec Ice Storm Project, Projet Verglas, validates this, and it gives evidence that neurosteroids are involved in making lasting changes, specifically epigenetic modifications. So the Quebec ice storm was actually a succession of 5 storms, and it coated southeastern Canada with 5 inches of ice in January 1998. And then it got colder, and they were stuck with this encasing of ice anywhere from 2 weeks up to several months. 25 people literally froze to death. And a number of other people drove because, well, you know, the famous last words of a redneck, hey, y'all, look at this. You know, they were out cutting donuts on a parking lot and driving badly and God knows what. But the Project Ice Storm was created by some very sensible people to monitor the outcomes of 178 pregnancies during and shortly after the storm. And they found that the stressed mothers' babies had shorter length and smaller head circumference at birth. They had a poor temperament as infants. Now, I'm not sure about the French. No, it's French Canadians, and their temperament is fairly notorious. But even for French, they were fussy and difficult. They were dull, and they needed attention. God, that is sad. And they, interestingly, had dermatoglyphic asymmetry, and it's a schizophrenia marker, just the marks on their palms. And when these stressed babies were toddlers, their intellectual function was reduced, and they lost about 2/3 of the standard deviation in vocabulary. By age 6, plus or minus a half, the children had lower full-scale IQ, verbal IQ, and language ability. They'd impaired neuromotor function, although the girls were doing better than the guys. At 6.5 years, autism spectrum screening questionnaire scores correlated with prenatal maternal stress. And the kids who are the most vulnerable were the fetuses who had been in the first trimester during the storm. And if spanning all the way from age 5.5 to age 15, higher prenatal maternal stress was associated with greater children's body mass index and central adiposity. And that association got stronger and stronger as the kids got older. And they had a questionnaire called Eat 26, and the kids were more vulnerable to eating disorders than non-stressed. At 13, prenatal maternal stress predicted childhood asthma in girls. The same thing the Aussies found, completely unrelated. And what it is it's an elevated immune response because immediate stress increases the immune sensitivity, right? So they found increased immune markers correlating with mom's prenatal maternal stress level. They had reduced total and CD4 plus lymphocytes. They had increased production of nasty cytokines, tumor necrosis factor alpha, IL-1B6, and enhanced Th2 cytokines, which cause autoimmune diseases, IL-4 and IL-13. And so the authors said prenatal maternal stress is a long-term programming factor. Now, this is pretty interesting. How did women respond to being under 5 inches of ice for anywhere from 2 weeks to a couple of months? Some women responded really well, and some women were freaked out. And so the project compared the objective measures of how much the woman really had to endure with how much mom related the experience of her stress to try to quantitate. And they found that the objective, the measurable bad stuff that happened to mom, mediated abnormal glucose and insulin metabolism. Yes, the kids are born insulin resistant. And by that effect on the childhood BMI, the daughter's reduced age at menarche. And the abnormal E26 eating disorder risk questionnaire most strongly related to mother's stress in the 3rd trimester. And then the project looked at the mother's subjective report, how freaked out she was by the events. And the freak outedness most strongly mediated the bad infant temperament, the dermatoglyphic asymmetry that correlates with schizophrenia, neuromotor dysfunction, and undesirable autism spectrum screening questionnaire scores later on. So why were these results different? Well, you know, moms had different types of stress response. All of them were objectively stressed, and all mothers had an acute stress response. But then some of them could kind of let it go and say, okay, I think I'll just bend with this. And others continued to suffer and got into the chronic stress response, which I touched on in the adrenal lecture. Acute and chronic stress produce different responses. And here's a nice Crusos is the golden Greek. I mean, anything you read by this guy about stress, take it to the bank. He's phenomenal. He's now chairman of endocrinology at Athens after working at NIH or big American places for years. So, did a pessimistic outlook worsen the in utero endocrine environment? And then we say, well, can prenatal maternal stress cause epigenetic changes? Because you guys have noticed that these changes carry through at least to age 15. And from the Dutch hunger winter, we know it goes to the next generation. So this is now the fetal programming hypothesis based on studies of pregnant stressed animals. And it holds that increased maternal cortisol can alter fetal brain development. I don't know if you guys know, but we're really not supposed to give a Medrol dose pack to a woman in the 1st trimester of pregnancy. That's just no bueno, okay? Anyway, these enduring changes are linked to epigenetic modification of the DNA. And so Project Ice Storm wanted to investigate this. And so we have now another term to define. What are epigenetic changes? Epigenetic changes are modifications that are made to your DNA, not of the fundamental base sequence, but it's applied on top of the DNA. And it blocks DNA transcriptions and it silences genes in areas of DNA. So it can turn off stuff. And there are 2 types. You can methylate the cytosine guanine bond. So you take a little CH3 group and you stick it right in between the cytosine and guanine. Or you can change histones. Histones are the proteins, the like great big spools that package DNA. I always think of on my fishing pole, the reels in the fishing line to keep from snarling up. That's kind of what histones do to your DNA. They keep it reeled and available when you need it. Think of a Torah scroll, right, Bruce? But these changes to the histones include all kinds of shit: methylation, acetylation, ubiquitination, phosphorylation and sumoylation. Oh, not everyday words in my vocabulary. And these changes alter gene transcription, and they do so in different manner. And these changes, the epigenetic changes, are all driven by enzymes. So what the hell regulates the enzymes? Well, they think that steroids are involved, okay? Epigenetic changes in utero are believed to direct normal fetal development and differentiation. So the kids are klutzier, they got a bad personality, they got a smaller head, a smaller body size, more insulin resistant. And it's supposed to make kids better responsive to environmental changes because not every hunger winter lasts only 6 months, or not every storm lasts only a couple of weeks. Think of the 100 Years' War. And so all of these changes, it seems, are supposed to enhance the survival of the species, if not make the individual more fabulous. Okay. And guess what? Neuroactive steroids mediate epigenetic changes. Steroid receptors exert epigenetic changes on the developing CNS, says the Journal of Neurosciences. Gonadal steroid hormones and their receptors, acting along with coactivators and co-repressors, yin-yang at a smaller level, orchestrate orderly patterns of acetylation of histones associated with specific genes. So we're deciding what genes we're going to play, what genes we're not going to play, and it's decided by our neurosteroids. Some genes are silenced in males, yes. Others in females to direct normal differentiation, and comme on dit en français, vive la différence, no? So Projet Verglas investigators tested the DNA methylations. You have to use a very flat A if you're saying French Canadian. Verglas. That's the way those guys talk. Maternal stress modulates these DNA methylations to adapt the child's genome to stressful environment, which could explain the enduring effects. Yes. And the mother's objective prenatal maternal stress and the methylation levels were correlated significantly at over 1,600 CG islands or CPG islands. That's the methyl group that's stuck between the C and G on the DNA that blocks its reading. Over 1,600 of these. And the methylated CGs were associated with a total of 957 genes. So when you get a mother who's seriously stressed, it's really going to change the way the child reads the DNA, doesn't it? And those 957 genes were spread out over 22 chromosomes. And the most methylated gene of all was LTA, lymphotoxin alpha, which is involved in regulating, the innate and adaptive immunity, which is maybe why we're seeing the asthma. Isn't that fascinating? And wow. So knowing that prenatal maternal stress altered the Th1 and Th2 cytokines in blood from the 13-and-a-half-year-olds, they looked and found, there are epigenetic modifications on the nuclear factor kappa B pathway genes that link objective prenatal maternal stress with the children's immune shift towards a Th2 state, which is to say autoimmune. Okay. So in conclusion, maternal stress mediates epigenetic changes in the child detectable in adolescence and is mediated by neurosteroids. Now, they took a look at the mother's subjective stress. In other words, how much was the mother freaked out? And again, I love the word catastrophizing. That's, we see that in some of our patients, that everything is a freaking catastrophe. So they checked it. And just to remind you guys that stress determines mother's cortisol release, whether it's physical stress, environmental stress, or simply learned stress or emotional stress. It all affects mother's cortisol, and the cortisol affects the baby and the baby's exposure. So they found that children of distressed mothers had far more methylated CG islands, more than 2,800 than those of the stressed mothers who were more optimistic. And that was a significant difference. So, the Buddha's right. Attachment leads to suffering, and suffering screws up the kids. Subjective stress is more damaging than objective. And I'm so glad you're watching Spruce and Jocelyn. Well, you knew this already. You guys knew that. So in review, epigenetic changes cause stable silencing of genes. And by this, relatively few steroid molecules can impact a large number of transcriptional responses spread out over 22 chromosomes, adapting to changes in the physical or even social environment. Although we lack full understanding, it is apparent that steroid hormones influence these epigenetic changes, and so steroids select which DNA will be transcribed. Now, the clinical applications. When Jim asked me to start this, it took me more than 7 months to do the literature review for this lecture. But this fortune cookie arrived while I was doing it. If the brain were so simple we could understand it, we would be so simple we couldn't. I love the way the universe sends me relevant fortune cookies. So when I searched neuroactive steroids, I got over 1.2 million citations in PubMed. And so I said, oh, damn those basic guys. And I added human neuroactive steroids. And I got almost 650,000 references. And I have, lots of reference notes to share. And I, of course, in this lecture have just scratched the surface. There's so much. But I'm telling you, this stuff I think is useful and interesting and just cool. So what can we take home to the office? Adrenal dysfunction is proposed as the most parsimonious explanation for the global reduction in GABAergic neuroactive steroids in women with prior depression. Isn't that awesome? So that gets back to my adrenal lecture and, post-traumatic stress. And a depleted adrenal gland lacking nutrients, overworked, underfed, is going to reduce the steroids that mellow the brain. And I gave my stress lecture to NCIMS and I haven't given it to you, so my apologies. But I got a few suggestions I'm going to repeat. And these are going to be familiar to you. Chronically stressed, pathologically fatigued patients respond really well to nutrients that are required by the synthetic enzymes of the steroid pathways. And in preparing this lecture, I realized that these are not adrenal supplements. They supplement also the gonads, the brain, the mitochondria, and any other steroidogenic organ. And so I recommend cytosine AD, an adrenal glandular that's proven to work like Capsi in my patients. And you give them at appropriate times of the day and bedtime. And remember, the nutrients go to the brain. And then, as indicated, you can add in over-the-counter precursors of reliable quality, like pregnenolone and DHEA, and follow their results with laboratory tests, which I measure blood progesterone and testosterone these days. And you want to balance the gonadal hormone. The importance of accounting for and balancing women's ovarian hormones has been described. And nothing pisses me off as much as the GYN saying, well, she's had a hysterectomy. She doesn't need any progesterone. Just give her estrogens. People need balanced hormones, guys. And we talked about men getting their hormones out of balance. Their estradiol too high for their testosterone in the men's TRT lecture. So the study of neuroactive and neurosteroid hormones has also emphasized the protective and, anti-aging effects of proper hormone replacement therapy. And Dana mentioned the paper that was published in June looking at every single woman in Medicare in the United States, comparing those taking hormone replacement and those not. And the women on hormone replacement older than 65 had significantly healthier lives and longer lives. Pretty amazing. So the benefits of ensuring women's optimum hormones include protection against a number of CNS insults, including stroke, Alzheimer's, general oxidative stress, and CNS inflammation. There are a few of many references. Those are the ones that came to hand. Estrogens modulate cognition and behavior and protect you against dementia. women are twice as likely to develop Alzheimer's dementia as are men. Why? Because their sex hormones drop and men's are much slower to fall. And there was a French study of over 5,500 people who showed a J-shaped association between women's estradiol levels and the risks of dementia. That's pretty fascinating. So enough is enough. Too little or too much is bad. So that's sort of the inverted peak that I showed. Too little is bad. Too much is bad. Just right is sweet. Paul Sarrell has calculated that more than 40,000 women have needlessly died or prematurely died of heart attacks, cardiovascular disease, because they stopped their hormone replacement after the WHI study in 2002 misinterpreted their data. And of course, WHI has since withdrawn the data and said, oops, we were wrong, but they never said we were wrong. But 2019 JAMA. Also, progesterone has a significant protective role directly as progesterone and by conversion to other neurosteroids, including allopregnanolone. And these protective effects of progesterone are to protect neurons from excitotoxicity and ischemia and reduce peroxidation of membrane lipids. Progesterone decreases the mitochondrial reductive oxygen reactive oxygen species production, oxidative stress. It reduces inflammation in the brain. It protects neurons against apoptosis with ischemia, and it preserves white matter with a cord contusion in trauma patients. And it might even stimulate brain repair. However, synthetic progestins, including Provera and levonorgestrel and other progestins, whether they're progestational or androgenic, they're not neuroprotective. The progestins don't protect the brain. It's only natural progesterone. So why would you use a progestin? And as I said many times, progesterone is a precursor of allopregnanolone, and like estradiol, too much or too little allo is bad. Low allo, yes, it's found in Alzheimer's and in senile dementia. And if you give HRT with progesterone, you will increase the allo levels in human plasma, and it's been proven in these old studies. On the contrary, synthetic progestins like Provera and levonorgestrel, et cetera, reduce allo production. So you have more of a deficiency of allo that's associated with senile dementia and Alzheimer's. So guys, use bioidentical. Androgens also, believe it or not, can be neuroprotective. Just simple over-the-counter DHEA and its sulfur conjugate DHEAS, which especially comes from the first pass when you swallow a DHEA capsule. Those guys are neuroprotective neurosteroids in multiple animal models, but they haven't done it in people yet, as far as I can tell. And both of these androgens protect the hippocampus against the glutamate, AMPA, and kainate toxicity. Those are the glutamate receptor subtypes, if you remember. So these over-the-counter androgens are neuroprotective through multiple mechanisms, probably most importantly via the sigma-1 receptor I mentioned earlier. Testosterone has been shown to reduce brain inflammation and traumatic brain injury, although probably is by conversion as a substrate into other metabolites, including estradiol. When you validate Shores, Shores was the first person to show that men with low testosterone die inappropriately quickly. And many, many studies now have validated that low T means higher death rate. And when doctors will treat prostate cancer with androgen deprivation, either by castration or chiectomy, I should say, or chemical blockers like Lupron, there are many undesirable consequences of getting too little testosterone in these guys. And there are some reviewers who have actually asked, man, is it worth the risks? Because this is bad treatment. It causes a lot of problems. Are you really getting that big benefit from the cancer? It's still up in the air. But both sexes need the right amount of androgens for their sex. And then looking at the ice storm data with objective versus subjective stress, just feeling distressed increased the harm received. And it seems more likely to prolong acute stress into chronic. And chronic stress is where so many of our patients come in to see us. And releasing the distress feeling can reduce suffering. And I've cited the Buddha, but I should also cite Bruce and Jocelyn. These guys know that. They're psychiatrists. It's important to integrate the patient's medical care with skilled psychiatric and psychological support. Now, our polluted world is full of endocrine disruptors on which I've touched just ever so lightly. And for the optimistic and well-funded, I mean, it's lovely to think about minimizing exposure to environmental toxins. And God, I hope Bobby Kennedy Jr. gets in someplace important and can help us do that. But the most common endocrine disrupting factor I've encountered in my practice is insulin resistance. Insulin resistance with a poor diet and lifestyle just worsens many bad effects. Insulin upregulates women's 5-alpha reductase, virtually guaranteeing an imbalance of neurosteroids. Men's high insulin upregulates aromatase with mirror image undesirable consequences. And those of us who understand insulin resistance, we're equipped to advise patients of just the fundamental steps to prevent its complications, which include obesity, PCOS, metabolic syndrome, infertility, menstrual disorders, hypogonadism, type 2 diabetes, heart disease, non-alcoholic steatohepatitis, and stroke. So if the diet and lifestyle won't work, if the allo remains modest and there are no symptoms of high allo or withdrawal, so women's cyclic allo-related symptoms respond really well to, holy shit, 5-alpha reductase blockers, saw palmetto. And dutasteride has been proven to be successful. But one PhD just had kittens when she saw me even mention the dutasteride study as being really a beautiful study. It was. They proved that 5-alpha reductase causes PMDD in at least 75% of their women. But saw palmetto, and there are other natural 5-alpha reductase blockers, including St. John's wort, including reishi, including turmeric/curcumin. All of these things that people take for headaches are 5-alpha reductase blockers. So yeah, they work. Yeah, they do prevent menstrual headaches. But a 5-alpha reductase blocker, especially, God forbid, dutasteride, really should not be used in pregnancy or when nursing a baby, because the baby will get too much of the 5-alpha reductase blocker and actually may not develop properly. Now, is that in literature? No. Do doctors prescribe herbal remedies like curcumin, turmeric, like reishi to pregnant and nursing women? Yes, they do. Should they? I'm not going to. Okay, that makes me nervous. I don't want Junior to be born without all of his pieces parts. Now, we've seen that PCOS pregnancy hurts the kids. What about the moms who don't qualify for PCOS? I mean, they looked at the obese mice, they had damaged offsprings. PCOS is a very specific diagnosis, and some people don't quite qualify for it, even though they're obviously insulin resistant, heading in that direction. So what's the problem? Is it the glycemia, or is it the insulin and the neurosteroids? And our colleagues in obstetrics routinely monitor the glucose level in pregnancy, but these guys ignore the insulin. And I showed you last time the insulin response of Beth, my woman who got tested early and late in pregnancy with the hyperinsulinemia, horrendous. So I've shown you those guys before, but this is the hyperinsulinemia of pregnancy, before pregnancy at 15 weeks and at 30 weeks. How about that hyperinsulinemia when the OB is going to say, oh, your glucose is just fine? Is there a need to study insulin in pregnancy? Yeah, I think so. When more than a third of adults over 20 are obese, when over 10% of children aged 4 to 17 have ADHD, when about 1 in 68 children is on the spectrum now, holy shit. Holy shit. I mean, everybody's talking about forever chemicals and PUFAs. What about our insulin and how we're eating and how we're not exercising and how we're stressed? I mean, really? is this stuff preventable if you diagnose hyperinsulinemia and you reduce MOMS5 alpha reductase and androgen production? Maybe. Some of it is, I think some of it is. So the brain is affected. So in conclusion, yes, the brain is affected by peripheral steroids. There's the classical estrogen, progesterone, testosterone. And then there are these, what I used to call in my ignorant days, I called them precursors and waste products. And now I know they're neurosteroids like pregnenolone and DHEAS and tetrahydrocorticosterone. They're not wasted. They just work somewhere else in a more subtle way than classical endocrinology could ever find. The brain makes its own steroids also de novo, or by just modifying a progesterone or an estradiol it can catch and making it into something else. And remember, the classical steroids act on the nuclear receptors, and the neurosteroids bind the non-genomic receptors. Steroids modify our brain's development by both genomic and epigenetic effects, as we've seen. They modify the brain balance. They tune the inhibitory versus excitatory synapses so that maestro can play on a piano that's awesome. They modify the brain output, meaning cognition, learning, and mood and behavior, right? And then they will preserve your brain and protect it from degeneration and damaging stressors like hypoxia. And then pathology will impair the brain's neuroactive steroid balance, and it leaves the brain vulnerable. So I think if we understand how neurosteroids work, it will allow us to understand better so we can intervene to identify and repair imbalances of the peripheral steroids. I'm not sticking a needle in anybody's CSF. I'm not, or in their brain. But you know that if their gonadal hormones are jacked up and completely out of balance, so's the brain. You know this, man, because they go right into the brain, okay? So we just look at what we can measure and balance that. And hot damn, maybe we've done something really good for the brain. I think there's promise of being able to accomplish a lot more as more research is done, but I ain't going to do it. I'm an old geezer. But my advice to you guys is don't wait for some guy who's over there tormenting rodents to develop another drug. Apply physiology to get at the cause of the problems: diet, sleep, lifestyle, nutrition, balancing hormones when the glands aren't working. Use the physiology to get good outcomes with our patient. And the final wisdom from the universe, this is my fortune, says the great aim of education is not knowledge, but action. So I hope I think I carry this stuff out, and I think it really affects the way I treat my patients. And even when I'm teaching testosterone and estrogen replacement, I mean, I'm not talking about neurosteroids, but in the back, yes, we're affecting the brain and all these other things when we do that. So that's my lecture, and I hope it didn't put too many of you guys to sleep. Cool.
No, that was pretty awesome. Can you hear me?
It was it was a lot of fun doing it. I got to tell you, it took me over 7 months, and my God, incredible numbers of references to see if I could remotely understand what was happening. I usually, if I'm going to research a field like reverse T3, I go in PubMed and I go to the first article they have on file that mentions reverse T3, and I go from the oldest to the newest because there's so many changes. And yeah, if you pick it up in the middle, you will be lost. But in neurosteroids, I had to start with the newest articles, and I found a few I really liked, and I went to their reference list and I pulled the references out. So I worked back that way. So I don't know if there's any room for questions, but I'd sure be glad to entertain them if somebody has a thought.
Okay, well, let me see if people put questions in. So the first question for everybody is, or just a statement for everybody, is that next weekend is a holiday weekend and I am not available to proctor. And so I think we're going to skip Labor Day weekend and
Sounds
do
good.
the final wrap-up lecture on the 8th.
Okay.
So just if the email turns out to not be correct, just I told her already, don't put the wrong date in the email, but you know, every now and then it gets wrong. So,
Okay. Now,
um,
I'm sorry.
also,
Go ahead.
would you mind horribly if I put this lecture out on YouTube
No.
so anybody can watch it?
No, I think it'd be great. I hope I haven't offended anybody. Is there anybody who thinks it shouldn't go out onto YouTube? Because I'm really tired. So I may be a total asshole.
I mean, I have where on the steroid pathway is allopregnanolone? Oh,
It is hanging off the side. What happens is progesterone on my steroid pathway. Did I put it on the slide? I can't remember. But if you go to progesterone and you look for an arrow pointing up at 2 o'clock on the clock face, there's an intermediate that's moved by the 3-alpha HSD. And then allopregnanolone is the next step up from the intermediate, and it's modified by 5-alpha reductase.
okay.
Thanks, Mason.
Very
Appreciate it.
cool. That's Brian.
Oh, dang, you fooled me. Okay. But thank you, Brian.
Can I ask one verbally instead of typing it out?
Of course. Oh, yeah. Preferred.
Yeah, so I had a patient that somebody else had put her on hormone replacement therapy.
Yeah.
I do a fair amount of hormone replacement therapy, even though I'm a psychiatrist, because for 20 years nobody else would do it. Getting
God
better
bless
now.
you, Bruce. You're a good man.
But
Yeah.
well, you know, fools go where anyhow.
Where angels fear to tread.
Right. But so somebody put her, if I recall properly, it was a patch that had estradiol, which was nice, but it had a progestin rather than progesterone.
Yeah.
And after some months, she started getting a whole bunch of very weird symptoms. So I got her to go off that. And things are getting slightly better, but I have some vague memory that the progestins, the synthetic hormones altogether, can really accumulate in the body and might take months to get out. But there's no way to measure it.
There's no way to measure it. They're invisible to the lab. You know, it's intriguing. I can't really tell you that, but it's plausible. It's plausible. You know, men who have bodybuilders who have cheated with anabolic steroids, and they've completely suppressed their HPG axis. Some of them never get it back. Never. It's lifelong. They're fucked. So would the progestin do it? Yeah. Now I have a patient who's a chiropractor, and she had a progestin-eluting IUD for 5 years, and it started to create some real mood and affect problems. And so we replaced it, and her husband got snipped, and I think she's doing considerably better. So progestins, and I looked it up on Google, and it said yes, after 5 years, something like, you know, maybe as much as 20% of people can complain of mood and affect problems using an levonorgestrel, well, progestin-eluting IUD.
Yeah.
So it's not a go, you know, like $200. It's not perfect.
Right. But the thing is, and this was probably 10 years ago, and I'm just not systematic enough to keep track of these things. But I
You mean your
seem to
memory's
be-
not perfect?
But well, one could stash it away in the computer somewhere if you can find it.
So you're still using a computer you had 10 years ago.
But I ran into some source that basically gave a figure and said that it might take 6 to 12 months to get the stuff out of you. And so if that's true and we don't know that, then that really messes up trying to fix it, because in this case, I'm telling her, well, we'll add in a little bit of progesterone, but we'll just hold it there for a good long while and see what happens.
I haven't been slow. And, you know, I usually start out, now she needs the progesterone to protect her uterus. Is that what it is to protect the endometrium? So she's on HRT with estradiol and progesterone because she's still anatomically intact with the uterus.
Yeah.
So I think I'd put her on a full. Now, look, what I've been doing lately is maybe not excellent, but When I start a woman in that situation on HRT, I give them 100 milligrams of permetrium, and I tell them, look, this is peanut oil. It can make you sick, and it's got all kinds of stuff in it, and a lot of people don't like it, but it's inexpensive, and it's right on the druggist shelf, and your insurance will cover it. And then I check their blood levels if it's well tolerated, and sometimes I'll go to a compounded progesterone, 70 milligrams, 60 milligrams, whatever they need to get a good balance of their blood levels. But whatever you do, I think I would give enough progesterone so that the GYN isn't going to have a fit. And if the thing to be aware of is your patient may get a big time headache. Lots of women get headaches with PMS, and that's when you start the supplemental. You stop the progesterone for a week or two, get the supplement up to speed, and then you can reintroduce the progesterone. I've had lots and lots of my women develop, well, lots and lots, but I'll put a surprising number over the years say, no, I can't take hormone replacement because they get terrible, horrible headaches. And it's because they're taking natural progesterone. It doesn't happen with the Provera because it's jacked up and it doesn't affect your neurosteroids. But biologically identical progesterone will cause headaches, and it does it by the allopregnanolone thing, and the supplement prevents it. And they don't need a hell of a lot. 160 milligrams a day takes care of most of my menopausal women who thought they couldn't tolerate progesterone.
And then if you wanted to be more cautious, I gather one can start just with some pregnenolone, which I understand will give a certain amount.
That's what I did for years, and that was wrong to stop there. It's a good place to start. The safe thing about pregnenolone is the body will not make more progesterone than it should have. Okay. The bad thing is it can't make enough progesterone to balance the estrogen replacement in the luteal position.
Yeah,
but yeah, pregnenolone is a great place to start.
Okay.
I hope I didn't wander too much. You still with me, Lisa? Thanks.
All right. Yeah, I don't see any more questions. Anybody else have anything they want to come on and talk?
Hey, Alan, I just want to say I'm sorry for the loss of your father-in-law.
Well, thank you. He was a sweet, incredible man. He could fix anything, but the problem is he got Parkinson's way back about 2010, and he completely lost his mind. I mean, believe me, the lights were on, but he wasn't in. And so he just gradually went down, and it's a huge relief. Natalie, my wife, went in to see him right after he died, shortly after midnight. And she looked at me, she said, "Oh, Dad, I'm so glad you're free." And then she burst into tears, which is, I think, a pretty healthy reaction.
Yes. Yeah, thank you for coming on and teaching this.
It's such a privilege. I mean, I got to tell you guys, what am I supposed to be doing here? I've already had kids, if I can just spread something that I've learned and help you guys help your patients, I'm totally honored and thrilled to do that. So thank you for giving me a reason to be here.
I told somebody the other day, I thought your hobby was reading journals, and I was like, you got to get a better hobby than that, dude. At least you've got a dog.
Yeah, and a cat now,
and
an 8-year-old.
And an 8-year-old. There you go. That's good.
But well, my father and grandfather were engineers, and then my other grandfather was a Bellevue trained a GP, and at Columbia and Bellevue. So I'm a perfectionist. I like to know how things work, and I want to apply it. And I'm really grateful for Dr. Google and Wikipedia, because they are really good guides to get you going on a PubMed search. PubMed search engine isn't the best.
Sure. I agree. All right. Well, cool. I guess then we will.
Hey, it's before 9.
I know. We'll see everybody again in 2 weeks.
Now, question.
Right.
While we've got people here, I have an hour and 15-minute lecture on combining reverse T3 and adrenal that I gave for ICIM. And I'd be glad to give it after the final lecture if Dana can stand one more week, and if you guys want a review of adrenal and thyroid. It's, like I said, it's updated. Oh, thank you, Lisa. It's updated, and it's, you're going to see a lot of the same old slides. Well, thanks, Bruce. But if I'd be happy to be cool with it, if you guys like.
All right. I can stand it.
And it's a good lecture. So
when we get into the fall, does anybody object to starting a few minutes earlier, just maybe even 15 minutes earlier as we go through into the discussion group time? I mean,
yeah, I can do that.
usually we only spend an hour or so in discussion group. We don't spend 2 hours like we've been doing.
Depends on how succulent a case people bring.
Right. Yeah, everybody get your cases ready.
Get some juicy ones, y'all.
Oh, I got a backed up list of them for you. so-
Oh, wait a minute, I got a long list too.
I'll
Not
fight you
keeping.
for it.
They'll keep us warm in the winter. That sounds
That's
good.
right. That's right. I've got a pile of them. They're piling up.
And the only thing I can guarantee is I'll give you my best effort. I'm not gonna. I do not carry tablets of stone with inscriptions by the finger of God.
Right.
Moisha, I'm not. So
Okay.
we're all bozos on this bus.
All right, cool. Well,
Okay.
we will see everybody in 2 weeks, and yeah, I may say when we get to discussion group that we start about 15 minutes earlier, if that's all right with you.
Thanks, guys. Really appreciate y'all being here. Good night, folks.
Cool.